Okay, now that we have a little bit highlight of the understanding for eye, let's go through the eye. So what is this? Is the hole, is the pupil. What is this? It's the iris. What is this? It's the whites of your eye called the sclera. On top of the pupil, what is this clear coat? It's called the cornea, right? And then the lacrimal apparatus. So this one is actually pretty interesting. Think of it this way. Let's say that I have a patient. If most of you, I would suspect at least half of you have gone in to get your eyes checked, right? To see whether or not you need glasses. So when you go into the optometrist's office to get your eyes checked, they initially, for inspection to actually look into the eye, they'll dilate it. So they'll give you something called atropine. And atropine is a muscarinic blocker, right? So it blocks the parasympathetic nervous system. So parasympathetics would cause pupillary constriction, and blocking pupillary constriction means that you have pupillary dilation. When you dilate the pupils, you allow light to get in, and you also allow the physician, or in this case, the optometrist, to look into the eye to inspect it, right? To look at the retina, look at the optic disc, and see if there's any kind of bulging or any problems with the eye. And so what happens is you can potentially have a patient that takes home a drug similar to this. And let's say that this is a muscarinic blocker that opens the eye because it does the opposite of pinpoint pupils. But atropine is a muscarinic blocker. And let's say it's an older patient that is forgetful and they're forgetting that they put the medicine in their eye. And somehow they end up at the hospital and they have elevated heart rate, right? So let's say they have elevated heart rate and they're not on any medications, right, except for the eye drops. So they mention to you, let's say they mention to a nurse and they don't tell the physician that they're on atropine because that might not be a medication that you're considering to look at. And they tell the nurse, oh, I'm on atropine and, I forgot to take my dose. I need to take it again. I need to take it again. And then you find out that atropine, what can it do to the heart? If I overdose, it would take a lot, but this is theoretical. If I overdose, I put way too much atropine into the eye, doesn't it go into the lacrimal duct? Doesn't the lacrimal duct connect from the eye to the nose? So when you cry as well, right, your nose, all the tears go into your eye and then they pass into the nose and they cause it to swell. So same thing. If I have atropine that goes into the nose, that means there's a potential for me to swallow it. If I swallow it, it gets into my intestines and then it absorbs into my blood. Then it circulates throughout my blood and then it ends up at the heart. So let's say muscarinic blockers like atropine end up at the heart. What's it going to do to heart rate? Well, if I take my foot off the brake, right, because this is blocking parasympathetic, and for the heart, the brake is parasympathetic, so this is a blocker of parasympathetic. So if I take my foot off the brake, then the gas is on. That means that the heart rate is going to go up, cardiac output's going to go up, this person's blood pressure might also go up because of it. So just food for thought. The lacrimal duct is a passageway that goes from the eye, right, into the nose. So lacrimal duct is here, goes from the eye into the nose. So there's always the potential for medication that's used for the eye to essentially get into the system. 3 layers of the eye. I'm not going to test too heavily in terms of this, but you are going to need to know the structures, not associated with this, but the structures in general for the eye. Here we go. Light, crispy apples, very pricey. Ogo. Light passes through the cornea. Crispy apples, right? So what is this? Aqueous humor. The pupil is the hole. The lens. The lens can adjust. It can either bulge. So there's 2 ways that you can adjust an image onto the back of the retina, which has the photoreceptors that need to receive the image in order for you to see the image clearly. The lens can either be flat, well, not extremely flat, but as flat as it can possibly be, or it can be round, so I'm going to over-exaggerate the 2 of these. What is the difference between a flat lens and a round lens? Well, let's look at this as a fishbowl. Let's say that the fishbowl is very round, and you look into the fishbowl. The fish, as it moves towards you, or as you move towards it, it starts to bring that illusion of you getting closer and just being completely distorted. So when I round the lens and make it look like a rounded fishbowl, it's for images that are close. So an image here would be transmitted there. Okay, so just remember, close, fishbowl, round. So when you have an image that gets close to you, your lens will round to adjust and accommodate to it. What about if I want to see far? Imagine sitting in your living room or in your car. The window itself, right, is flat. The flatter the window, the clearer it will be for you to see far. If you round that window in front of you, what's going to happen? Well, the image itself is going to be brought closer to you. Another way to think of this is your side mirrors, your side view mirrors. They'll have a little rounded object, and it always says objects are closer than they appear. Well, what is it doing? It's bringing the object closer so that you can see it a little bit better. But fishbowl, easiest thing for me to remember. And this one, window, a flat window. So window for far and fishbowl for close. Window, far, fishbowl, close. So we'll also talk about what corrective lenses you need to use for someone that has far-sighted vision versus somebody that has nearsighted vision. Okay, let's continue. So we said APL, right? Lens. And then what is this? Vitreous humor. And then the light information lands on the retina. What's contained on the retina? Photoreceptors. What are the two types? Rods and cones. Which one is for night vision? Rods. Which one is for color, clarity, acuity? That's cones. But specifically, there's a point called the fovea, also known as Fovea Centralis. Here is something to remember for that. Fovea Centralis. It has the highest abundance of cones. And what are cones for? Cones are for color, clarity, and acuity, right? So this is what we call the Fovea Centralis. It is a yellow spot on the eye. It is also a dark spot. So we're going to translate what terms that they use to describe this. Yellow is, spot is macula. Okay. If I want to say a dense spot, I just say macula densa. Densa can mean dark or dense. And if I want to say a yellow spot, I say macula lutea. So both of these can be used. This one's not as commonly used. It's really hard to find in textbooks or even doing online research, but it is there in some of the books that you read. But macula lutea is the yellow spot of the eye, which is also a dense spot, and it has a dense amount of cones. So if I want to see something clearly, what do I have to do? Where do I have to put the image? I have to put the image not just on the retina, but I have to put the image specifically on the fovea centralis, where I have an abundance of cones so that I can have color, reception, clarity, and acuity of the object, right? So clarity means clearness, basically how distinguished you can get the features, right? If it doesn't fall on the fovea centralis, then what's going to happen to the image? What happens to peripheral image, the image that you see in the periphery? Is it clear or it's a little bit blurred? Typically it's blurred, right? You're not going to see it clearly until you actually look at an image. So here we go, fovea centralis. And then once the image hits here on the photoreceptors, you're going to have information that passes through the optic nerve, then it crosses at the optic chiasm, then goes through the optic tract, finally through the lateral geniculate body into the geniculocalcarine tract, and ends up in the I keep saying that, occipital lobe, which contains your visual cortex. Awesome. Keep going. So same thing, light crispy apples, very pricey ogle. This is your optic nerve, goes to optic chiasm, goes to optic tract, and etc. This you can do if you want to memorize it. The cornea sclera, just the fibrous outer layer, but that one you can kind of, it shouldn't be too hard, but I won't really test on it. And then vascular layer, I told you choroid, what was that for? That was to absorb the extra light that might be shining into the eye. And then the very inside, the neural layer, is just the retina. So it's the cornea sclera on the very outside to protect the eye. The iris, the choroid, all of that is a part of what they call vascular layer, has your blood vessels. And then the neural layer is just your retina. There we go, light crispy apples, very pricey ogle, again and again. What do I have in high abundance here? Aqueous humor. So if I have a patient that has glaucoma, what is glaucoma? It's an elevated eye pressure, right? Due to either excess amounts of aqueous humor production or not being able to remove the aqueous humor through the canal of Schlemm. And then if I have clouding of the lens, what is that called? That one is called cataracts. And how do I treat it? you can replace it or just deal with the blurred vision, right? So if I need an image to fall in order for it to be clear, have acuity, and be in color, it has to fall where? On the Fovea Centralis. Good. So sclera, whites of the eyes. I'm just going to go through this quickly. Same thing, same image, right? They're just focusing and reminding you. Iris is the colored portion of the eye. It surrounds the pupil, which is the whole of the eye. Pupillar dilation and pupillar constriction. Which one is associated with parasympathetic? This one or that one? Well, pinpoint pupils, parasympathetic. Which one is associated with sympathetic? Well, this guy. If you're scared S-less, right, you're running away from a lion, then you need to let the light in. So you dilate the eye with sympathetic nervous system. Or this would be an example of blocking parasympathetic by using something like atropine. The terms that you need to memorize are mydriasis and meiosis. So mydriasis sounds like a really long word, so it's probably going to fit into the one that has the biggest diameter. So this one is pupillary dilation, and it is called mydriasis. And then the one that sounds really tiny is pupillary constriction, and that one is meiosis. Not to be mistaken with farsighted and nearsighted vision. So we're going to do farsighted and nearsighted. Farsighted is hyperopia. So you can just remember vision as optic nerve, it's associated with vision, right? And then nearsighted is myopia, right? So it's the shorter of the two words, so it's probably associated with being able to see things that are close and not being able to see things that are far. So myopia shorter, hyperopia farther or longer. Here we go. Let's keep going. Ciliary body. Choroid. So choroid is what you have for absorption of extra light that's going into the eye. Ciliary body, I do like this, but I don't really cover it for this level. It is essentially, when we're talking about the lens, it has fibers or string that are connected to muscles. So ciliary body has the muscles that either contract or relax to cause tension on these fibers that attach to the lens. Fastest way to think of it, if I have a balloon, and let's say I have a balloon here. If I pull on the balloon, what happens to the balloon? It becomes flatter. So if I want to see far, I'm actually going to cause tension inside of these fibers to cause the lens to become flattened. For those of you that are maybe taking the 300 level, we'll just go through it. What happens when I contract the ciliary bodies and the muscle inside of it is that when I contract it, it causes the muscle to move forward, and it causes these fibers to become relaxed. When I relax the fibers, like letting go of a balloon, what happens to the balloon? It wants to naturally become a ball. So the same thing, when I contract the ciliary muscles, this is not for my class, I'm not going to test this. So when I contract the ciliary muscle, it causes the fibers to relax. It causes the lens to bulge for nearsighted. So it allows you to see something, an object, as it's getting closer to you. If I relax the ciliary muscles, then it causes the fibers to become tense. The more tense you are, the flatter your lens will become, so it allows you to see far vision. That is FYI. I'm not going to test on it, but there is something that I am going to test on. And it's called accommodation. Your ability to accommodate. So accommodation. I might have too many M's in that, but that's okay. Right now we're just going to get through the material. So accommodation is, just watch my eyes. Okay, so ready? Oh, wait, let me turn it so that, okay, so what did I just do? So I had to converge my two eyeballs. So part accommodation is this. I converge the eyes. So there's convergence occurring. And then what is the second part of accommodation? Well, as an object becomes nearer, right, the lens must bulge. And why does it bulge? In order for you to see things that are coming closer at you. What happens is you get older. your ability to accommodate becomes less. Maybe not that your muscles themselves are not able to do it, but your ability of the lens to bulge and change shape decreases over time because you have more deposits of protein and other products into the eye or into the lens. This is the lens. And it makes the lens stiffer and stiffer. So over time, if you notice, as you get older, your vision when you're reading something gets a little bit farther and farther. Okay, you guys won't see that for a long time. I'm not there yet, thank goodness. Okay. So ciliary